University of Witwatersrand, and I'm going to just present this really rapidly progressing field, and it's a very exciting field to be in. Oh, hang on a sec, sorry, technicals, there we go. I was thinking about this talk yesterday, and I think I should actually call it Orange is the New Black. So Orange is the New Black is a TV program about women in prison, and it refers to things changing and fashions changing. And what I see, and I want to call my talk TB is the new HIV, because what's happened in our TB environment is that things stayed the same for almost all of my career with no changes in treatment guidelines. And now all of a sudden we're seeing rapid changes in our guidelines, new research being presented at international conferences every year, but not new variations on the theme, totally new things. And it reminds me very much of the early days of HIV research when things moved so quickly. The only problem is that TB physicians are often a little bit slower in their ability to respond to changing in guidelines and to changing in ways of thinking. I'm going to just set the scene quickly. I know that most of the people on this call are probably in South Africa, but just to remind ourselves of where we are in terms of the world burden. And I'm going to give a short history, a short, almost shameful history of the way we treated rifampicin-resistant TB prior to 2010. And then I'm going to talk about the new evidence and what we're currently doing in South Africa within our program. I'm a bit of a jack of all trades, while I'm a clinical trialist by profession or by choosing. I've spent a lot of time working with the National Department of Health to ensure that the research that's being conducted within South Africa is rapidly adopted into our TB guidelines. And it's pretty easy in the field of rifampicin-resistant TB because the treatment outcomes were so abominable. So in South Africa, we do bear an extraordinarily high burden of TB disease. Although our population is 0.76% of the world's population, we have 3% of the worldwide burden of TB. Part of that is driven by our HIV epidemic, and also it's driven by the fact that we have really good diagnostics that we can diagnose both rifampicin sensitive and resistant TB through rapid diagnostics. And I think that we probably are finding many more patients in other countries. That I will put as a caveat, as that's my opinion. So in the olden days, so this was pre-2010, we used a 20 to 24 month regimen for the treatment of rifampicin-resistant TB, or MDR, so that's rifampicin with INH. It was a combination of what I term fondly the kitchen sink approach, where we chucked just about everything we could at the patients and hoped that it turned out all right. And our outcomes were abysmal. For two reasons. One is this is a very intolerable regimen and involves the use of an injectable agent for a minimum of 6 months. And so we battled to keep our patients in care, and many of them were lost to our program. And so intolerable medicines, poor efficacy, terrible side effects meant that we had a really poor outcome. And then that was followed by the first randomized controlled trial. And yes, that is what I said, the first randomized controlled trial for the treatment of rifampicin-resistant TB that was ever conducted. Although we had kind of played in the field developing drugs like bedaquiline, where it was put against a standard of care, this was the first time when we looked at 2 treatment regimens and randomized patients to the 2. In this case, it was a shorter regimen, still containing injectable agents, and that was compared to the standard of care, which I've just presented to you. A quick rundown of it. What we can see is that still in this 9-month or so-called Bangladesh regimen, we still used a minimum of 4 months of injectables. And prothionamide, we used to use ethionamide in our program, is kind of like the poor man's INH, lots of side effects and less efficacy, same kind of resistance patterns, was still included in this regimen. These 2 regimens were compared, and strangely enough, a couple of things came up. The first one is that the success rate in a clinical trial was way in excess of what we expected from our programmatic data. In our program, we were getting about a 45% successful treatment outcome. But in this trial, both the study arm of the short 9-month regimen plus the 24-month regimen actually approached 80%. It was conducted in part in South Africa, where we had quite a quarter of the patients came from South Africa with at least a 50% HIV co-infection rate. So this set us on a pathway to say, how short can we go? We used to do 24 months. Now we've gone down to 9. Still a pretty intolerable regimen, but can we go any further than that? And with that was this revolutionary trial called NEXT-TB. It's got a bit of a strange history, so bear with me for a second. It was conceptualized in about 2012. And at that stage, what we then defined as extensively drug-resistant TB had about an 80% poor outcome. So people who presented to our program with rifampicin-resistant, fluoroquinolone-resistant TB, 1 in 5 of them survived. Very poor outcomes. At that stage, neither bedaquiline nor linezolid were incorporated into our guidelines. So in conjunction with the TB Alliance, we kind of embarked on this really, what I thought was a brave trial at the time. We combined bedaquiline with pretomanid, a new agent, a dihydral nitramidazole, with linezolid at a very high dose. It was watched very closely by the FDA, and we had to present patient outcomes for every 15 patients that we enrolled. The dose of linezolid was extraordinarily high, and that resulted in you can see the purple line at the bottom, that about 81% of our patients had some degree of peripheral neuropathy. And this ranged from, in the main, a grade 1, so kind of pins and needles that disturbed people's days, to severe peripheral neuropathy that didn't resolve. But the outcomes were flabbergasting. In fact, I have been accused of research fraud because of the results of this trial. 9 out of 10 of our patients had a favorable outcome at the end of treatment, and then 24 months after the end of treatment. So we followed our patients for 2.5 years. And 92% of the patients, or depending on which category we looked at, roughly 9 out of 10 had a favorable outcome. It was a simple regimen, easy to take, but limited by the high dose of linezolid causing lots of side effects. So that led on from the rather strange number of 109 patients randomized to a new study design where we compared the same population, but we randomized to different doses of linezolid. We liked the 9 out of 10 patients cured, but we didn't like the adverse event profile. So in the sister study Xenex, what we did is we randomized in a blinded fashion the dose and duration of linezolid. So neither the clinicians nor the patients knew how much linezolid that they were getting. Sorry, that jumped. So the highest dose was the official NICS regimen, and the lowest dose was linezolid given for only 2 months. And if we have a look, we preserved that really high outcome rate. The sample size was probably a wee bit small to make any great judgments on it. But of the patients who got only 9 weeks of linezolid had a slightly lower successful outcome rate. But again, we preserved this 90% of success rate. And that was combined with the fact that as we decreased the duration of linezolid, we decreased the severity and number of side effects. Linezolid's principal side effects, and they are a cause for concern, is peripheral neuropathy, and it does seem to be overrepresented in the South African population. More to follow as we collect more data. It may be a combination of HIV co-infection, nutritional deficiencies, maybe substance abuse, but it seems to be a little bit higher. And we can see that as we decrease the dose and duration, the highest dose and duration, 37.8% of patients got peripheral neuropathy, as opposed to when we went to only 600 milligrams for 9 weeks, only 13% got. So, and that was replicated in all the adverse events. Optic neuropathy is an common side effect, but all 4 of the cases of optic neuritis occurred in the highest dose and duration of linezolid. And anemia, which is in fact of more concern, decreased as we decreased the dose and duration of linezolid. Now, of course, peripheral neuropathy is painful. It's a pest, but it's not life-threatening. As opposed to anemia, particularly in our patients who've got quite severe lung disease, dropping a hemoglobin down to 6 can be life-threatening and even fatal. And this is one of the concerns that we have around the shortening of treatment, the use of linezolid in shortened treatments. Then along came another study called BPaL. It was conducted by MSF in a number of different sites. And what the BPaL study design did is it compared the WHO standard of care, that awful 9 to however long months of treatment with injectable agents. And the BPaL study design looked at 3 other arms. All of them had a bedaquiline, protomid, and a linezolid backbone. One had moxifloxacin added, one had clofazimine added, and one was just BPaL on its own, as described in the NICS trial. At 34 weeks, they compared the efficacy of the 2, and almost a statistical aberration in many ways, because there was very little to choose between the 3 arms. They decided to continue with BPaL, bedaquiline, protomid, linezolid with added moxifloxacin. The other 2 arms, the one with clofazimine and the one with nothing at all, performed slightly worse, but they still achieved the go, no-go criterion. But they decided to go ahead with a regimen that contained moxifloxacin. And that was compared to the WHO standard of care. I haven't included the latest publication that came out quite recently, but that gap between the addition of a second drug has closed as more and more patients have reached a study endpoint. So that just sums up what I said, and BPaL-M was selected to continue for the regimen. You don't have to be a betting person to guess which one fell off, and that was, needless to say, the long 9+ months of treatment that contained an injectable agent. And the reason that it dropped off was because many patients were either lost to the program or alternatively had 1 or 2 drugs replaced because of the adverse events associated with those drugs. So the study was stopped prematurely, and they continued to follow up the patients in all 3 arms, but the bulk of patients were randomized to the BPaL-M arm. And what we see is a massive difference between the 2, that the standard of care people fell off all the time due to usually to drug toxicities. Again, this was a really obvious conclusion, but it's nice to see robust clinical trial data supporting our treatment guidelines for drug-resistant TB. As mentioned, I spend a lot of time working with the National Department of Health, and we are very privileged to have someone who's in the lead of the National Department of Health's TB program. Professor Norbert Njeka, the professorship, he was awarded a PhD from your university, but Professor Norbert Njeka is an incredibly forward-thinking guy about incorporating new changes in treatment guidelines. As part of one of the other studies I was doing, we were awarded some funds to conduct the BPaL Clinical Access Program in South Africa. At that stage, when we initiated this program, we did not have the data back from BPaL. So the decision was made after long consultations and talking at the National Clinical Access Committee to decide whether we should add moxifloxacin or not. And the decision at that stage was not to add moxi, and just to treat our patients on BPaL at various sites. Sorry, it's got the wrong date on it at the bottom. So the BPaL Clinical Access Program was initiated in 5 provinces. in April the year before last. And the province, it's being conducted in Gauteng, Northwest, which is a province with a lot of mining activity, KwaZulu-Natal, the Eastern Cape, and in the Western Cape. And the way that it works is that patients who present to those sites who wish to participate in the clinical access programs are kind of on the edge between research and programmatic implementation. But patients who presented, and I'll talk about the inclusion criteria in a second, were offered a position on the trial. If they want to go ahead, what would happen is that we have a pre-approval mechanism where the clinicians at the site check that everything is in order with the patient, so make sure that the diagnosis of TB is correct, and mainly that all safety parameters are fulfilled. It's presented to the National Clinical Advisory Committee, and there's usually a competition to see which two of the clinicians on the committee can answer first. So we respond very quickly. What's unusual about our clinical access program, and similar programs have been conducted in other countries, in particular in places in Eastern Europe, Ukraine, Moldova. It's starting to kick off in the Philippines, a very high burden drug-resistant TB area. So what we did for the bedaquiline clinical access program is that the age at which we could enroll patients, because of the way the original trials were set up, was 14 years and upwards. So obviously anybody between the ages of 14 and 18 required additional parental consent, but that was our cutoff. And after long debate, what we decided to do was to treat people with pulmonary rifampicin resistant TB with quinolone resistance, and that's now got a new term. We now call it pre-XDR TB. So that's a slam dunk. That's the trial in which, that's the exact population that the trials were originally targeting. But we also decided that patients who were quinolone sensitive, and if the clinician felt the patient would benefit by a shorter regimen, it was presented to the National Clinical Advisory Committee, because strictly speaking, this is off-label use of a regimen. And if the committee agreed, the patient was randomized, was enrolled onto the bedaquiline clinical access program. We've allowed 56 days of exposure to bedaquiline and linezolid prior to enrolling on the trial. We would exclude patients if they'd had 56 days of exposure to delaminid, the other nitramidazole, except for the very few of those around. But if there was a concern about resistance, we would talk about it to the National Clinical Advisory Committee. After lots of debates and arguments, we decided to settle on the following: that patients will be given bedaquiline as per the current package insert, which is 400 milligrams for 2 weeks, and then going down to 200 milligrams 3 times a week for 6 months. We originally started at the higher dose of linezolid, but clinicians were very reluctant to use that. And as soon as the original results of Xenex came out, we'd reduce the dose to 600 milligrams. And then pretominid we keep at the standard dose of 200 milligrams a day for 6 months. Bedaquiline and pretominid, if there's an adverse event associated with them, they can be stopped, and then the whole regimen is stopped for a period of time. And if the adverse event resolves, then they can be reintroduced. And liver toxicity is the one that falls in here. But linezolid can be interrupted, stopped, but we have decided against the use of a 300 milligram dose in patients with TB, because consulting in the huge body of evidence, which is not all that great, probably we are going below the therapeutic level of linezolid. And the last thing that we want to see is linezolid developing within our program. So if a patient gets a treatment-limiting toxicity, and it's usually anemia in the first 8 weeks and peripheral neuropathy from 16 weeks onwards, we either stop the dose until it reverts, or alternatively, we stop it permanently. So we presented the results of our bedaquiline pretominid linezolid clinical access program to the DSMB, as we do every 6 months. And this is the data that we obtained from the data lock at the end of last year. At that stage, we had put 159 patients onto treatment. Average age was very similar to that within the program. We've only enrolled one person under the age of 18, and I think that reflects poor diagnostic practices in young people. The BMI was a normal BMI with a couple of people falling on the underweight group. There were more men than women, and I think that that's tipped over because of the site that we are enrolling in Sepang, where it's predominantly serving a mining community. Most of our patients were Black, and more than half of our patients were HIV co-infected. All patients are initiated on appropriate antiretroviral therapy, and fortunately we now use dolutegravir, which doesn't interact with bedaquiline, so it doesn't really matter what the patient was on before. We tend to put them onto a combination of TLD, or if there's renal dysfunction, abacavir. So, and obviously the initiation or continuation of antiretroviral therapy depends on normal clinical guidelines. Of the 159 people that we started on treatment at this data lock, 124 of them had completed 60 days of treatment. And you can see my last statement is, and were not found to be resistant to bedaquiline. And herein is one of the biggest concerns that we have. Of the 124 that were enrolled, we do cultures as per the National TB program, so the figures are not all that tight, but by the end of 2 months, 76% of our patients had culture converted. So they would have had a culture at 0, 2, 4, and 8 weeks, and 2/3 of them had culture, 3/4 of them had culture converted by month 2. That's, of course, an excellent response. We're very happy with that, because the sooner people culture convert, the sooner they get better clinically, and also the less of an infectious risk they are. And if we have a look at the number of patients who've completed 6 months of treatment, this is excluding the numbers that were withdrawn prematurely, almost all of them culture converted by the time they had finished 6 months of treatment. So what this is showing is that in a programmatic setting with the hodgepodge of patients that present with all the problems that human beings have, we can still get the same kind of success rate. This is a work in progress, and we are continuing to enroll patients, and more outcomes will come out. But what we are seeing is that this is not dissimilar to the clinical trials. And I think what we've done is we've hit the sweet spot. What we have found is a short regimen with few pills that don't interact, and we can keep our patients engaged in care for a minimum of 6 months, which is the time that most of our patients require to be cured. So who didn't make it to the end of 6 months? We've had 10 early withdrawals. In this population group, high rate of HIV infection with pre-XDR TB or fluoroquinolone-sensitive rifampicin-resistant TB. We are not particularly surprised at the fact that we've had 2 people who have died within this population. We feel, reviewing their death reports, that they were related to neither TB nor the treatment that we were giving, but almost always to advanced HIV disease. We've only lost 1 person to follow up, but these are very resourced units where we can phone our patients and even go and pick them up. We've had to stop 3 patients prematurely from the trial because of adverse events. 2 of them had optic neuritis early on in the treatment, and therefore we had to withdraw them from the trial. And 1 had quite severe peripheral neuropathy early on in the treatment regimen, and therefore we had to change to a linezolid-free regimen. But of much more concern, and I guess I've highlighted in a jaundiced color, is that in the group that we've enrolled, we have found 4 patients with bedaquiline resistance. And that is a cause for concern, and we're seeing a similar result in another trial that I'm conducting called Beat Tuberculosis. So bedaquiline resistance is a real and present danger in our program. One of these patients was exposed to bedaquiline during the lockdown, stopped his treatment and then re-presented to the clinic after having taken only 19 days of bedaquiline. And when we did a phenotypic bedaquiline resistance test on this patient, he was found after a really short exposure to have developed bedaquiline resistance. The other three, as far as we can ascertain from their records, acquired bedaquiline within the community. So this is a potentially transmitted bedaquiline resistance. And this really changes the game, because if bedaquiline resistance is occurring, one of the key drugs in our regimen may no longer be effective. I want to pause for a little bit to talk about what the National TB Program is doing about this. Embedded in our program is anybody who has a diagnosis of rifampicin-resistant TB with additional quinolone resistance, has a phenotypic bedaquiline resistance test done. There are 5 big TB labs that conduct them. If there's any question about the validity of the result, then that's shipped up to the NICD in Johannesburg, where it is confirmed. The problem with culturing as a method for finding resistance is it takes us quite a long time to find it. And it is not the fault of the lab, it's the fault of the fact that it takes this period of time for the TB organism to grow, and then once that is established, to decide if it's phenotypically resistant to bedaquiline. And most of these patients we found their bedaquiline resistance 4 to 6 weeks after initiation of therapy. I think that this is a thing that we really need to be focusing on. First of all, is getting more rapid diagnostics. I'm not a microbiologist, and I do understand that bedaquiline is a relatively new drug, and we don't fully understand the implications of bedaquiline resistance and what the mutations mean and how severe that resistance is in terms of its impact on. It's not a black and white kind of thing. Is this almost like the 3TC of TB treatment that perhaps has some benefit, or we can't count it as a full drug. But this is a cause for concern. The National TB Program and the WHO is more than aware of this. South Africa consumes more bedaquiline than almost all the other countries in the world put together. It's only relatively recently that other big countries like the Philippines, Russia, it's always difficult to get data out of, but other big countries have really been using bedaquiline across the board. So we're the early uptakes, and we are starting to see resistance developing. And there's a lot of focus on trying to find a genotypic test for bedaquiline resistance. So what we see is that the clinical access program conducted at routine sites has been successful. But in amongst all of this, the WHO decided to endorse BPaL on the basis of very small number of patients on practical, to endorse that as the treatment for the vast majority of patients who present with rifampicin-resistant TB. And that is what the National Department of Health has decided to adopt, that we will be using BPaL in almost all of our patients. I'm not sure whether moxifloxacin adds anything, and I'm not sure, in addition to that, whether it will do any harm. However, it is an extra medicine to take. Doesn't seem to have all that much effect on QT prolongation, but it's a very weird thing that's occurred now, is we say to someone, you've got rifampicin-resistant or bad TB, so we're giving you 4 drugs. You've got pre-XDR TB, so really bad TB, we're only giving you 3. Makes no sense, but that's the way the WHO has come out with it. We're in the process of completing the guidelines for the adoption of BPaL, and they should be available by the end of this month. And the plan is to start the rollout of this regimen, originally starting at the clinical access sites where we've got clinicians who are well versed in this treatment, and then we will kind of make babies. So we'll spread it within the provinces, and it will soon be the treatment of most South Africans, or most people who live within our borders who acquire rifampicin-resistant TB. So what I mentioned is that the WHO has, again, in its wisdom, and I think correctly in this case, changed the definitions of the type of TB that we see. So we still call it rifampicin-resistant or MDR if there's additional INH, But the truth is that the addition of INH resistance doesn't make all that much difference to outcomes. And we've removed INH from the treatment of rifampicin-resistant TB in the main. We now term pre-XDR TB what we always used to do, which was a patient who is resistant to fluoroquinolones. So rifampicin resistance plus fluoroquinolone resistance. We stopped using injectables in our program in 2018. So for a long time, we've got the result back that they're injectable-associated mutations, and we've ignored it. So what we've really done is we've kind of on our own decided that pre-XDR TB is fluoroquinolone-resistant TB, and it doesn't seem that the outcomes of additional injectable resistance makes it any worse. But we've redefined the XDR TB. So XDR TB used to be INH and RIF. Now we just say rifampicin-resistant TB with resistance to two fluoroquinolone plus any other category A drug. I haven't presented the slide of what the category A drugs are, but the way the WHO qualifies them is that category A are the drugs that increase good outcomes, so that's treatment completion and cure, and decrease bad outcomes, and they focus particularly on deaths. So the three category A drugs, the heavy hitters as it were, are bedaquiline, and we're not surprised at that. Linezolid, which is a very good TB drug, not so good for patients, but a very good TB drug. And the third category A drug is a fluoroquinolone. So now if you've got resistance to two of the three category A drugs, that is termed fluoroquinolone resistant, termed XDR TB. The category B drugs are clofazimine, which is a useful TB drug, but it is not liked by clinicians or patients, and therefore is slowly, I think, although it's an effective TB drug, it is falling out of fashion. And the other category B drug, so this is a drug that increases good outcomes and doesn't seem to decrease bad outcomes. So the other category B drug is cycloserine or taururzidone, a drug so old that was registered before even I was born. And it was registered on a neuropsychiatric indication and then found to have TB activity. So that's a just quick, short summary of where the TB drugs actually fit. Sorry, the slide's not meant to be here, so I'm going through all of those. Oh, I've lost my last slide, so I'm just going to talk through it and stop sharing. So in summary, we have seen a rapid change in the treatment guidelines for rifampicin-resistant TB. It used to be a harsh treatment that produced the treatment of MDR-TB had low efficacy, high toxicity, and produced side effects that were permanent in our patients. I could swap that out with the use of stavudine, that while it did save lives, it caused permanent side effects. And we've changed from that to a much shorter regimen that's been endorsed by the WHO, bedaquiline, protominoid, linezolid with or without moxifloxacin. And it's being adopted throughout the world, and it's being adopted in addition in South Africa in a pretty rapid way. People who get TB, and people particularly who get rifampicin-resistant TB, live in overcrowded situations. They are often impoverished. They have many problems. When I've looked a patient in the eye and told him that he or she has got XDR TB, and they say, that's not my biggest problem in my life right now, that is a person with a lot of problems. Financial instability, maybe substance abuse, and all the other things that go with having recently emerged from a pandemic in a country that has power maybe 20 hours in a day. So we are dealing with a population group that needs as much help to be able to be adherent to therapy. We're seeing increases in our success rate in our program because of the use of bedaquiline, then linezolid, and then other shorter regimens. So it's a great step forward, but behind us is standing this ogre. What if bedaquiline resistance develops? We are doing surveillance for it, but if it gets any worse, if it affects more of our community members, what is plan B? And I'm going to leave it there. Thank you very much.
Francesca, thanks for a really wonderful talk and laying out this incredible work that you've done. I mean, it really is tremendous, and thank you for everything you've done, and particularly struck by this critical link between science and the trials, but the implementation. And I know Norbert is a driving force, but I mean, I think you and others also should take a bow. So, absolutely fantastic. If colleagues have questions, including in the room, please could you raise a hand on the participants list. While you're thinking, I'll perhaps start. I mean, you went back to 2010, but of course, just prior to that, I mean, we were using Rifafort plus streptomycin, in fact, as the sort of as the second line regimen, weren't we? Which was for drug-resistant TB, really, because these people were failing and many of them had it. So even further back, and even worse drug. I wanted to ask you though, two questions. One is, in terms of the bedaquiline resistance, is there any thought about doing targeted surveillance, not just in the drug-resistant population, rifampicin-resistant population, but in the rifampicin-sensitive population to get a better handle? I know, appreciating all the difficulties and challenges of actually doing the phenotypic resistance, but it might give a better idea of the population level bedaquiline resistance at the moment if it's being transmitted. And the second question is about if you do stop the regimen, as you mentioned, the BPaL regimen, you said reintroduction. What's the guidance on reintroduction? And then once we've been through that, Tari and Adrian have their hands up.
Okay. So the first question is, what is the real burden of bedaquiline resistance? And at the moment, we're only really looking at fluoroquinolone-resistant patients. So to expand our understanding a little bit more, I've conducted a trial that I showed little bits of tidbits on it, called B tuberculosis, which was a very similar trial to BPaL, where we used a laminid instead of protominid. They're very similar drugs. The main difference between the two is cost. In that group, we found of our cohort of 400, 75 of them were fluoroquinolone resistant. And of those 75, 4 had bedaquiline resistance. There was a father and son pair, so it was obviously a transmission. I don't know where it started. But so that's leaving us at about 1%. We had a discussion around this trial recently with the trial steering committee, and now what our intention to do is to say, let's actually do phenotypic testing on the whole cohort. Because almost kind of logically, I think bedaquiline resistance would develop before fluoroquinolone resistance, because it's got such a long half-life that if you say start and interrupt therapy, the patient stops treatment after 6 weeks. Within about a week, that patient will be on bedaquiline monotherapy because all the other drugs will be gone. So the first thing that we're going to do is look at the rate of bedaquiline resistance in a well-characterized cohort of patients who have rifampicin-resistant TB. I think the one thing that I've learned in this is I'm never ambitious enough, because maybe what I can do is to speak to the NICD and say, why don't we take a sample of, say, 100 rifampicin-sensitive patients and run it through the same process. They are doing bedaquiline resistance, and I think although it's technically quite difficult to do, I think that's not a bad place to look. There is an overlap between resistance to bedaquiline and resistance to clofazimine. And aside from the fact that clofazimine adherence is often limited by the skin darkening, we have used clofazimine for quite a while in the treatment of drug-resistant TB. I don't think that we are reaping the consequences of that. I think that this is new, and I think that it is related to bedaquiline. And then your second question was how to handle linezolid interruptions. So in our cohort of BPaL, we've had patients who developed hepatotoxicity. We've stopped everything. Hepatotoxicity has settled down, and we've restarted the whole bang shoot as it was. But linezolid is much more difficult. and it requires a little bit more of an art than a science. Peripheral neuropathy tends to occur late on in therapy. So it occurs 16 weeks plus. There were exceptions and you've seen them, but generally it occurs at 16 weeks. If you've got a patient who culture converted by the end of their first month of treatment and are now on 16 weeks culture negative and clinically improved, we can remove the linezolid altogether if they are having treatment-limiting peripheral neuropathy. And that was done on the next trial and on the Xenix trial, that patients spent their last up to 2 months on 2 drugs. Now, everyone sort of raises eyebrows and thinks, what? But remember how we treat rifampicin-sensitive TB. We use 4 drugs for the first 2 months, and then we use rifampicin and INH for the follow-on. I know that I'm not comparing apples to apples, but the precedent of using only 2 drugs when there's a low bacillary load is not unheard of. Much more difficultly is what to do with patients early on a treatment who become anemic. And we have rightly or wrongly adopted a hemoglobin of 8 as our cutoff. I think it's throwbacks to ACTG days, but that's where it is. So if we see a patient, in fact, the doctors who work for me think that a normal hemoglobin is 10. It's not actually. A normal hemoglobin is 14. But many of our patients have anemia of chronic disease plus nutritional plus HIV stuff. So to see a patient who's enrolled on the study with a hemoglobin of 8.5, we don't phone up the NEJM and say, we've got an interesting case study here, it's common. And then if their hemoglobin drops a little bit below, particularly if they've got poor pulmonary function, it can get them into big trouble. And what we've done in those cases is we interrupt linezolid and transfuse at a hemoglobin of 8. And I think we've done that mainly, you know, the people who are going to be administering this regimen are generally going to be nurses, not even doctors. So we need a kind of somewhere to hang your hat on. And if we're wrong, they often can't assess signs and symptoms of TB, signs and symptoms of anemia, you know, murmurs, tachycardia. All of our patients are tachycardic. So that's just the decision that we've made. And in fact, 1 in 10 of our patients require admission for transfusion. And the cost of a transfusion is around the area of about 2,000 Rand a shot. So it's going to add significantly to the burden. But in these early on patients, we're dealing with a different thing. We're dealing with someone who's got a high bacillary load. And generally what we find is that the hemoglobin turns around on its own with a little bit of help and a treatment interruption, but will soon get back to above 8 and then will return to 12. So it's the difficult ones. And many of our patients also, they don't live around the corner and they don't have 4x4s to get to our clinics. So, you know, if we are at all in doubt, those are the patients we'll admit and transfuse. We've only had to retransfuse 1 patient more than once. So we give them a little bit of a break from linezolid, and a little bit is a week, and then reinitiate at full dose. So that's where the art and the science comes in.
Fantastic. No, thanks very much. So, yeah, fantastic. I'm going to actually take Adrian's question first, because in case Terry's controlling the room, so there may be more questions from the room.
Yeah.
But Adrian is solo. So Adrian.
Mark, thank you for hosting once again. And Francesca, what a fantastic talk. I'm a microbiologist here at UCT, and I wanted to know, because there's no DST test yet for susceptibility testing, it was recommended previously that one should monitor the patients by doing regular minimum inhibitory concentrations for bedaquiline. Was that possible in any of your trials, and would that be a possibility? Because looking at a summary of all the mechanisms of bedaquiline resistance, it's a kind of a nightmare. With ATP mutations, and there's some efflux, and this mutation doesn't increase the MIC, but that would be, I think it was the WHO recommendation some time ago, Francesca. That's number one.
So the NICD does do MICs on specimens that are referred to them. And watch the space. If I get invited back in a year's time, I'll have much more information, because what we're doing is we're now collecting that data.
Okay.
And we've also got serial cultures on our patients who then went on to develop bedaquiline resistance. And we're going to have a look at the MICs if we can pick up when it turned. We are actively seeking funding, and I think that we'll somehow fudge it to actually do whole genome sequencing on these particularly precious isolates, the ones that have developed resistance.
I mean, the frightening thing of all of this is that the phenotypic resistance to bedaquiline, you know, based on a summary of studies recently published in the JAC-AMR, is around 2.2%, where you will have a phenotypic resistance via the MIC increases or whatever test is done. But the frightening thing to me is that the genotypic resistance is more. It's double that. It's about 4.5%. So ideally, one should do whole genome sequencing before you start putting the patient onto bedaquiline, and that's going to cost a lot of money, and it would be very difficult to do. I mean, with the right bioinformatics, you can probably do it quickly, but that would be the problem, in that if you don't pick up these mutations that are genotypic before you even put the patient on treatment, it will express them down the line, as you eloquently explained. But thank you anyway, Francesca.
I think that, you know, as I said, I've got my foot in two camps. One, I love clinical trials and the work that goes with that, but also the fact that we have probably around 12,000 cases of drug-resistant TB occurring in South Africa every year. And the WHO has kind of suggested, and our national program kind of mandates, that people are started on therapy within 5 days of diagnosis by gene expert. So that's how the NTP monitors, and there's just no time. So would we be doing any harm if we initiated people on a bedaquiline-containing regimen and then did the background work as a reflex? And then at 2 weeks, we could say, oopsie, this is not going to work. But we need this parallel. The fact that a drug for TB was developed and delaminid and pretominid are right behind, without substantial understanding of how resistance works and what to do, then we need to up our game. It doesn't happen in other diseases.
I mean, but it would be possible to do whole genome sequencing quickly. You know, if there's an established pipeline parallel to your clinical monitoring. Anyway, thank you very much. I really enjoyed the talk, and I'm sure the audience did. Francis,
and the other thing that I want to say about bedaquiline resistance is that there have been people who've been shown to be phenotypically resistant to bedaquiline, but have had a good outcome. So they have been cured. And I think that that's starting to tell us that maybe bedaquiline half works or is not fully working, but the support of the other drugs, the fluoroquinolones, linezolid, and whatever else we're giving the patients, might be enough to cure some of our patients. It's an interesting field. We're going to get lots more information as time goes on.
Fantastic. Thanks. And over to the seminar room. So Tari, if there are questions. Can't hear you at the moment.
I think it's a Simon and Garfunkel song called The Sound of Silence.
Tari, if there are people who want to ask questions, they can come next door into my office, because we can't hear you. So while they're doing that, Francesca, to ensure that clofazimine isn't like bad shoulder pads can have to come back into fashion, your question about plan B is, isn't that pipeline? I mean, surely that's the plan B. So
That's the plan B.
Yeah, what is coming up that you think might be able to be used if that was the case?
So I think that there's interesting drugs about to enter phase 3, a TB Alliance drug that's also a dihydroquinolone. Oh, sorry, it's the end of the week. It's in a similar class to bedaquiline with a higher barrier to resistance. So that's pretty close. That will be one option. We need a safer alternative to linezolid, and that's not really resistance-based, it's patient-based. So that's pretty close. There's not all that much, and you're right. Or if you think of it in the greater scheme of things, 1% of 2% of the TB patients have potential bedaquiline resistance. We need to keep an eye on it, but we need to focus on our pipeline. I think that the original idea of the mechanism of bedaquiline was actually started in about 2000 by a guy called Andries Kuhn. And it only was registered about 14 years after that. We need to close that gap down. There are 2 EDCTP groups, one called ERA for TB and the other one called Unite for TB, that's really looking at drugs in the pipeline that can go forward into clinical trials. And then we need the same vigor to adopt them if they are good drugs. And in that group is a GSK drug. Someone also put forward a better and improved ethionamide, and I started laughing. But there are a couple of things in the pipeline.